Hello and good afternoon, everyone. Thank you so much for coming to our first webinar. By our, I mean SEAMSA's first webinar. So we have sent the invitation to a lot of people. So I'm just going to give a short introduction about SEAMSA. So SEAMSA is actually the association. Is the Southeast Asian Media Studies Association. And our executive director is here, Alexander. Alexander, would you like to say hi?
Yes. Hello, everyone. How are you doing? Thank you, Dr. Sabaria, for organizing this webinar. I'm so excited. There are 35 people here already. Very cool. So please continue.
Thank you so much. Thank you, Alexander. Yeah, so actually about more than 100 people registered. But in the interest of time, we will just begin the webinar and, the participants can come in at any time. So this is SEAMSA's first webinar, and this will not be the only one this year. We have lots of plans for webinars this year. So the webinar today is focused on health communication. And the topic is the effectiveness of COVID-19 vaccine campaigns. We are very, very, very lucky today because we have two expert speakers. We have Tina Purnat from WHO, and we have Associate Professor Dr. Mohamad from University Kebangsaan Malaysia, who is also part of UKM UNICEF C4D Center. All right, so I'm going to give a short introduction about Tina. Okay, Tina, say sorry to everyone. She has been urgently deployed for a WHO assignment and would not be able to be here today, but she has generously recorded before she went. So I'm going to play the recording, but before that, I'm just going to give a short intro about Tina to everyone. So Tina Purnat is team lead for infodemic management in a unit for high impact event preparedness, Department of Epidemic and Pandemic Preparedness and Prevention at WHO. So she's based in Switzerland currently. So in this role, she has pioneered advancement of infodemic management and infodemiology for promoting healthy behaviors in emergency preparedness, response, and prevention. So I had the opportunity to get to know Tina when I went through the WHO Infodemic Manager training. And so Tina has worked for more than 20 years with WHO, the European Union, and in the academia. So she's an expert in health research, analysis, digital health, and policy making. So that's Tina. And we are very, very lucky here as well to have Dr. Emma here. Dr. Emma, would you like to switch on your camera and probably just say hi?
Hi, hello everyone. Hi, Dr. Sabaria, how are you?
Fine, thank you. Thank you for coming and attending this, Dr. Emma. We have participants from all over ASEAN, from India, Philippines, and I see even one person from Germany as well. Yeah, so Dr. Emma is actually also the Deputy Dean of the Faculty of Social Sciences and Humanities at University Kebangsaan Malaysia. She has more than 18 years experience as an academic, and her area of expertise is health communication. So she's a health communication researcher, and she will be sharing with us, because she did a lot of research on COVID-19 vaccine. She also did on malaria, on diabetes, and all that. You can look for her papers. It's on a lot of Q1 journals, yeah, Dr. Emma. And she works closely with UNICEF and the Ministry of Health in Malaysia to design effective behavior intervention. So she's definitely the right person, to talk about campaigns and health campaigns. Right, so without further ado, since Tina is not going to be here, what I'm going to do is that I'm going to play her video. So it's going to be about 29 minutes long. Okay, and then next would be Dr. Emma and her presentation. And then we have a bit of Q&A as well. For those who would have questions for Tina, what I'm going to do is that I will copy the questions and I will ask her to answer, and I will email you guys with her answers. Okay, so I'm gonna start sharing my screen with for Tina's presentation. So hold on, yeah. Okay. So everybody can see my screen? So I'm just going to play it. Hold on. Okay.
Hi everyone, my name is Tina Purnat. I'm a team lead for pandemic management in WHO Geneva, and I was asked to speak a little bit today about the COVID-19 vaccines demand and its intersection with the infodemic, and how we could learn from the experience for preparing for the next pandemic. So first, I just want to start with basically reminding us that the willingness to receive a vaccine falls on a spectrum. It's not binary of refusing or asking or demanding a vaccine. Actually, most people fall somewhere in the middle, or they may have questions. They may want more information before they take action, and they may also take on this approach of wait and see before they decide whether to take the vaccine. And there's actually many factors that affect vaccine uptake. What I'm showing here is the WHO behavioral and social drivers model that was developed based on the best available evidence by a WHO scientific advisory group. And as you can see here, there's factors that affect the vaccine uptake may be related to risk-benefit perception, or social processes, basically existence of social norms that getting a vaccine is beneficial. Then factors related to motivation that basically affect intent to get vaccinated. And then there's a bunch of practical issues that also need to be in place so that the person actually takes the action to get vaccinated. And these are practical, and so availability, affordability, and ease of access to vaccines, or the person's experience of the service when they're getting used. Now, at the same time, what we also need to remember is that we live in a very noisy information environment. Everyone that's deciding to take the step and a vaccine, well, actually, we all live in this. So we all seek information from friends, family, and via phone screens every day. And we get constant streams of new information, and that can feel overwhelming. And this is especially true during emergencies, where especially then, because of that acute crisis, there's even more information that surges of different quality, including misinformation. And that can create even more challenge in recognizing credible, accurate health information from misinformation. Now, what I'm showing here is that the digital information environment can impact vaccine confidence and uptake, because in the information environment, there's very different type of media input into common vaccine narratives, including misinformation. And these in turn can affect people's knowledge and awareness and intent, vaccine confidence, and perceptions of risk. And that's particularly important for vaccines. So that's really important to reflect on. The majority of issues related to COVID-19 vaccine introduction, where people were not getting vaccinated, had to do actually more with access and service delivery issues than misinformation. The point here is that you need to first have equitable access to vaccines or demand. So think of it as this pyramid. You have to have supply, you have to have equitable access, and you have addressed those things, and if there's still a gap between how many people are getting vaccinated and how many people should be vaccinated, then it's more likely than you can attribute it to the demand-related factors. Now, the information environment can influence demand for vaccines, and we've seen that time and again for a huge range of vaccines, whether it's for Ebola, whether it's for dengue vaccine. So for example, the Invaxia challenge in the Philippines is a good example. We've seen this for measles, rubella vaccine. We've seen this for polio vaccine. And every vaccine has its own characteristics. It has its own unique factors that can make an infodemic more complex. So for example, the that happens, it's very difficult to dislodge this particular narrative, even if it's not true. To this day, Japan still has not recommended HPV vaccine as an addition to the national routine immunization schedule, in part because of misinformation. So that was one example. The point is that it's not uncommon for new vaccine introductions, or when you're trying to vaccinate people very quickly during mass immunization campaigns, and in an emergency, when you're trying to vaccinate people very quickly with newly developed vaccine, that a lot of issues that we saw during COVID-19 are going to surface also what was the state of the health system before the pandemic. There are only 4 countries in the entire world that had really strong adult immunization platforms. And we've had to see really what happens when a country has to very quickly figure out how to pivot from vaccinating only babies and children to suddenly try to find adults and trying to find populations of humans that have been prioritized for vaccines that just haven't been within the remit of an immunization program, especially in low and middle income countries, where vaccination is seen as routine childhood affair only and not for adults. So seasonal influenza vaccination programs are very weak in many countries and have extremely low uptake in many countries that do have those programs. So what COVID-19 has taught us is that when you're, for example, trying to identify who is immunocompromised, that's a little bit more challenging than figuring out who is a child, who is under the age of 5, and where to find them. And the same applies for other high priority groups, such as older people. Now, the reason why this matters in the context of the information ecosystem and the landscape, information landscape for older people is how they experience the information landscape. So, for example, we know that older people were less confident about COVID-19 vaccines. They have less digital literacy. They're more vulnerable to misinformation, and they're harder to reach. So they also tend to have less internet access than younger people. And again, that can affect their exposure to misinformation, and the information landscape can influence their perceptions and attitudes related to vaccines. And that can become then a real challenge. Now, it's also worth highlighting that because this was the same COVID-19 vaccine program that was happening all around the world simultaneously. Everybody was talking about vaccines, and this probably was the one point in human history where we never had more people talking about vaccines or about one particular issue simultaneously as much as we did during the pandemic. And that meant that vaccine developments or concerns or vaccine-related events, if they took place in one country, they could very easily become newsworthy and gain traction and affect vaccine uptake and confidence in another country. So for example of this include early issues related to blood clots for some vaccines in Europe and how that affected the debate about vaccines in the United States, Issues around concerns about swelling of the heart and myocarditis and endocarditis that also popped up among young people. And these are actually true concerns that take on more sinister perspectives and become misinformation or disinformation. And the point here is that it's not all concerns out there about vaccines that are untrue. Some concerns are entirely legitimate. So I'll give you an example here. Early on, we didn't have a lot of good trial data on how do these vaccines work in children? How do they work in pregnant women? And well, why? Because all of the vaccine trials are in healthy adults. So when we got to the point that vaccines were being recommended for broader and broader groups of people, including pregnant women and children, people had a lot of questions and people had a lot of concerns and trying to figure out the risk-benefit calculation for whether or not they should have their teenagers or their younger children vaccinated, or whether pregnant women should get vaccinated. Now, this is really important consideration because it's not misinformation, it's actual concerns, and those need to be detected as well as addressed, because if they're not addressed, they can very rapidly become breeding ground for misinformation. Then, of course, there's also worth highlighting that there are other factors that were promoting misinformation, either because this served a political purpose or served as a way for the promoters to benefit in some other way. And of course, there's also was disinformation strands around COVID-19 vaccines. But the point here is that that's a pretty small percentage of the sum total of conversations about COVID-19 vaccines. Again, actually, we don't know the true percentage of misinformation that makes up conversations about vaccines because it will differ from country to country. But the estimate can range from 5 to 20% of all conversations. And I think it's actually closer to the lower end. But the bottom line is that if you're just focusing on misinformation, you're missing the entire conversation. And that can affect your ability to address issues related to people's concerns and knowledge related to those vaccines, which again, if you leave those unaddressed, they can become breeding ground for misinformation. So what have we learned from promoting COVID-19 vaccine demand? One, you want to reach people where they work, live, play, pray, study, and gather. You need to bring services closer to the people you're trying to leverage, people's perception of the disease. So, and say, look, everyone's scared of COVID, but here's one thing you can do to protect yourself and your family. Get vaccinated. That can be a really, really powerful message, but that assumes that there are people who are not yet infected with COVID-19 vaccines, and they see the benefits of the vaccine versus getting infected naturally with the virus. It also assumes that there are social cues in the environment, that there are behavioral nudges around people that can make it the easy decision to get vaccinated. As social marketing expert Anton Schneider, who often lectures at WHO Infodemic Manager trainings, he says that if you actually want to make the decision to get vaccinated fun, popular, and free. So, in other vaccines, the disease is known, the vaccine is decades old and is well understood. Everyone understands the benefits of vaccination. No one wants to have their child to get the disease. So it's well socially normed that you get your child vaccinated. But in the context of the pandemic, especially if there's no vaccine there, of course, you're not going to have a social norm that supports vaccination in the pandemic if you've never experienced that before. Mm-hmm. What you also need to think about is how to do that. And a lot of that comes down to how you're designing your message, how you're reaching out to people, how you're outlining the benefits to vaccination, and how you're leveraging the trust between communities and health systems. This is really important because early missteps in the pandemic by some health authorities really decimated trust that some communities had in their government. And that meant that when it was time to roll out the vaccines, there wasn't a lot of trust to rely on. And it made it harder to get people willing to get vaccinated because they didn't trust the government. So early actions in the pandemic really influenced this success of immunization programs later on, whether or not the government was tracking the information or the information environment and doing social listening or doing infodemic monitoring in context of COVID-19 vaccines. The other component that is often an area of weakness is that there might have been monitoring and social listening, but not a whole lot of connecting it to public health action or using those insights for action. This is a consistent weakness that we've seen for the many immunization programs, although many immunization programs for other vaccines have probably been more successful with social listening, infodemic insights, because, well, they've been dealing with misinformation about vaccines for a long time. It's not new. And it's also not new that how it affects the success of immunization programs. But during a pandemic, you have to consider that there are new twists to vaccine misinformation that were not part of other recent vaccines. So, for example, that the virus is evolving, and so is the science about the virus, and therefore the guidance is inevitably always out of date and potentially confusing. The fact that early on, a lot of countries were constrained by supply issues. So for COVID-19 vaccine and then having prioritized populations who needs to get vaccinated, a really crucial step that was not taken by all countries was to recognize early on that if you're prioritizing health workers for vaccination, you have to ensure that they're confident in their decision, in the vaccines, and in their decision to take the vaccine, because then you may be able to ensure that they're confident also to address patient questions and concerns. Because if you can't even get really high coverage among your health workers, how can you possibly expect that those same health workers will confidently address misinformation and concerns and vaccinate others? So this is a really complex information ecosystem that goes way beyond just vaccinating children. Or, for example, in a way that you might run a polio campaign or a measles rubella campaign where the disease is known, the vaccine is decades old, and everything's quite well understood. Everyone understands the benefits to vaccination, etc., etc. Additionally, it's actually really important for the health system about really thinking about how science is translated and communicated. How are new findings, which may or may not support guidance related to vaccination, can also impact people's trust in government and trust in vaccines and in the vaccinators, in the system that it came out from. So, for example, early on, the pandemic vaccines were, the COVID-19 vaccines were considered to be a silver bullet. You know, they were positioned as if you get vaccinated, you know, you'll be able to end the pandemic. It's the best way to protect yourself and your family from illness. But then the signposts got moved as the virus evolved, and vaccines were evolved as well. So what it meant was that we were able to say, well, it prevents severe disease and hospitalization and death. And then later on, it became, the message became, well, it prevents hospitalization and death because there were so many breakthrough infections of people who were vaccinated. And yet, people still got COVID. So that's actually a problem. And again, this relates to people's understanding of trust and the government, because the goalposts keep moving as to what exactly this vaccine can do. And maybe this is also an unfair judgment by some, because it also underpins the fact that the virus is constantly changing and the arsenal of vaccines being used against it are constantly having to be updated as well, which meant that, you know, the first it was one dose and then 2 doses and then a booster and a second booster. And that also can impact people's willingness to get vaccinated, because suddenly it started more looking like a flu program, and if people had really low risk perception of flu, then it becomes just a part of something that's kind of optional, that you get also your influenza vaccine for. And now you had this COVID-19 vaccine, which is kind of becoming like an influenza vaccine, and it will be dealt with on a more seasonal nature, that there would be and there would be updated vaccines for it. So all of these different aspects impact people's confidence and vaccines in vaccines and their willingness to get vaccinated. So thankfully, globally, there's no evidence to suggest that COVID-19 vaccine attitudes are affecting people's attitudes about routine vaccines in a major way. This is still, but that's still a fear that many immunizations programs have, that because people have had this more antagonistic relationship with COVID-19 or COVID-19 vaccines, that would affect their willingness to have their children vaccinated for routine childhood diseases. But thankfully, there isn't any published evidence that supports this, but it's a worry. And what's concerning is the fact that you notice in general, it's hard to respond to the next emergency if the attitudes about COVID-19 vaccines are going to be similar to the attitudes, and it might be experience that we experience next time in the next pandemic, when there's a large epidemic and pandemic. So right now, it seems like when you conduct polls or surveys and you talk to people about their attitudes towards routine childhood vaccines versus COVID-19 vaccines, people seem to mentally categorize childhood vaccines into a different bucket than they do COVID-19 vaccines, which is a protective factor, I think, in terms of people's perceptions and attitudes about COVID-19 vaccines versus routine immunization. But on the flip side, what we know is one of the best predictors for whether or not someone was willing to get the COVID-19 vaccine was whether or not they had received a flu vaccine recently. So there's this relationship there between people choosing to get vaccinated against influenza and their willingness to get their COVID-19 vaccines. So it will be interesting to see if that relationship also bears out the other way around, because for example, if people who got COVID-19 vaccines, are they more willing now to get the seasonal influenza vaccine? And this will make a lot of impact, or it will matter a lot when we're planning seasonal influenza campaigns or strengthening pandemic influenza preparedness through strengthening seasonal influenza programs. Again, the jury is out on these relationships of perceptions, but it's something to watch out for. What I also wanted to let you just point out from the point of view of information environment is also that, local vaccine deniers have become very sophisticated in how they push their message and get around content moderation online. And the problem is that we don't have great ways of analyzing content with artificial intelligence or otherwise that's not based on text. So people really interact and live and communicate with video and images. And if we don't have more automated and more sophisticated ways of analyzing and tracking visual content, it's going to be a lot harder to address visual misinformation in the next pandemic or the next emergency that we experience. What I also wanted to show you is these 6 buckets of what are the most common narratives about vaccines. This particularly is was analysis of COVID-19 vaccine misinformation, but actually these apply to practically any vaccine. If we think about what is within the health system's mandates to be able to address when it comes to health misinformation and its precursors, this example is very telling. because there are 6 categories, and they span across development, provision, and access of vaccines, safety, efficacy, and necessity, political and economic motives, then linkage to conspiracy theories, linkage to liberty of freedom, and linkage to discussions of morality and religion. But how many of these can a Ministry of Health or a health authority really address? And unfortunately, not many of them. Out of the 6, only 2 related to vaccine development and necessity can be explained and addressed by a health authority. And in the other narrative themes, a health authority isn't best placed to address these. So really, how do we deal with this? This basically means that a health authority needs to partner with those who can address these narratives. And these may not be in the usual partnerships that already exist and that we have already built. Now, I won't go into a lot of detail here on this slide, but basically, if you think about that you have a certain menu of infodemic intervention to consider, and that you know that you need to have partnerships to be able to complement and strengthen what we cannot do alone, it's really, really important not to only look and concentrate on strengthening the capacities within the immunization programs, emergency preparedness and prevention, but also look at partners and capacities that we need to develop outside of the health system. And for example, partnerships with fact checkers is one such an example. If you look at all of these activities suggested on this slide, they all have one thing in common. They all position the health authority within the information ecosystem. And basically, we need to use our knowledge of how the internet works and how information is propagated by algorithms and people, and how it's designed to bolster against, how we can design to bolster against common psychological and computational vulnerabilities to mis and disinformation. The bottom line here is that if you're implementing an effective infodemic management strategy, you will not only have more of a communications presence in the information environment, you will actually achieve better decisions at individual, community, and health system level when they interact with the information. Basically, when you understand conversations and reactions and feelings and narratives in a population, infodemic management can help you keep your promises and help you deliver health to communities in ways that meets their values. So I want to leave you just with one last thought, because capacities for social listening and infodemic management that you build in routine can be surged for any emergency. And that means that the investment in infodemic management can really be tiny, or can be done in tiny or in giant health systems. But we all started pedaling madly like this one guy on a bike, not well resourced, juggling too many responsibilities and serving too many needs. And if we're lucky, then we get more resources and 2 more wheels, and we carry a bigger toolbox. And if you're lucky more, the road is paved for your success, and we get very comfortable seats and a massive toolbox to drive and about many infodemic challenges. But regardless of where you are, actually, this is not determined by the amount of money poured into this activity. It's really about infodemic insights, this type of thinking about information ecosystem being embedded in immunization programs and in other programs that are dealing with infodemic questions, concerns, information voids in an acute health event, in an emergency, or in preparation for an immunization campaign. Now, I gave you quite a lot of information. What I just wanted to also point out that this was just a little bit of a program of work that WHO has worked on over the last 3 years, specifically developing infodemic management and the underlying science of infodemiology, specifically to support not only the COVID-19 vaccine demand promotion, but in general the response, and now also response to other outbreaks that are taking place around the world. There's lots of resources available, and I invite you to look them up. But tools-wise, what I just discussed a little bit, also, for example, infodemic insights or how to address health misinformation, this is really just a tip of the iceberg. We have a lot more content and tools for you. They're coming to you actually also in the form of more courses over the course of next 2 to 3 months on OpenWHO, and I really do recommend that you look them up if you're interested. In the meantime, I do invite you to subscribe to the WHO Infodemic Management Newsflash. It brings along current information, papers, events that may be of interest to you. And I hope that this discussion was a little bit useful to you when we're trying to contextualize what we learned from infodemic, how it affected COVID-19 vaccine demand, and what potentially is their learning for us going forward. Thank you very much.
Right, so that's the presentation by Tina. I will be sharing Tina's deck and also the YouTube link with all of the participants today via email. So I was just like looking through the number of people vaccinated throughout the world. So only 67% of the world's population has been vaccinated, fully vaccinated. By fully vaccinated, it means they got 2 doses. And only 72.4% of the population in the world has at least 1 dose. So that means there's still around 28%, yeah, Dr. Emma, which has yet to be even vaccinated. And I was like looking through the countries, so I saw like a lot of the African countries are the ones which are least vaccinated. So I can't wait to hear what Dr. Emma has to say about COVID-19 vaccine campaign. So over to you, Dr. Emma.
Thank you very much, Dr. Sab. Hello, everybody. I hope you are well. I can see participants from all over the world, mostly from Southeast Asia, but I can see people from Germany, from Bangkok, Vietnam, Thailand. So welcome. I have actually been given this topic by Dr. Sab on effectiveness of COVID-19 vaccine campaign. So let me just try and share my screen. Y'all see my screen? Yep.
Yeah.
All right. Oh, great. Okay. So yeah, firstly, I'd just like to say thank you very much, the Southeast Asian Media Studies Association, for inviting me to your first webinar. And I'm just so happy that it's on health communication, and I'm so honored to be here alongside Tina to be sharing some of my thoughts on the effectiveness of COVID-19 vaccine campaigns. So first, before I go on to discuss on this topic more, let me just share with you. Let me just see if okay. So I just wanted to take a minute of your time just to share with you the organization that I represent in the university. Dr. Sab has introduced me as the Deputy Dean of the Faculty of Social Sciences and Humanities. But under the faculty itself, I'm also leading as the Director of HealthCom, which is a research interest center that was set up as a joint collaboration between the university and UNICEF as part of UNICEF's strategy to build communication for development capacity in different academic institutions. So in Malaysia, we have currently 3 C40 centers. One is in UPM, which focus on empowering youth. Another one is in University of Malaysia Sabah, which focus on marginalized communities, and UKM itself, we focus on health communication. So what we do is we want to advocate, for the recognition of communication itself as a strategic approach, as a very important tool and strategy for public health personnel, program developers to advocate for social and behavior change. So what we do is basically 3 main things. We develop curriculum at the university itself to prepare for future generation of health communicators. as well as train students who are already in the public health industry or health sectors on how to use communication for social and behavioral change. We also conduct trainings with healthcare providers. We partner a lot with Ministry of Health and the WHO in Malaysia in providing training that could help them to develop health intervention program that it's more strategic, using communication as tools. And we also conduct research that could help provide empirical data that could support C4D and SBCC planning in health. So basically, we're just 2 years. We're very still very young and very small, but very, very dynamic. So also an open invitation if any of you all are in the sector or are interested to collaborate with us, do just drop me a line on email or just visit our website to get more information. So, okay. So I have actually structured my presentation today in 3 parts. So what I'll start is I'm going to touch on some key concepts and definition of what campaign means. And this is to anchor my discussion on this topic. And after that, I'll be sharing some examples of COVID-19 vaccines and some of my observations on these selected campaigns. And also at the end, I would like to highlight some interesting development in campaign itself and some challenges and way forward that we probably could take to prepare ourselves for the next pandemic. All right. Okay, so I think most of us here are actually from media and communication background. And I think when we talk about campaign, we always see it as, rooted in media and communication strategies. And without no doubt, health communication campaigns have played a major role in healthcare, in disease prevention, in health promotion, and have made, a global, advancement in public health, as well as often considered as a critical component in health intervention efforts. And the thing is, when people use the word campaign, it usually means different things at different sectors. So some sectors actually regard campaign as an overall program, which may include the management, delivery, structure, resources, which may not necessarily how we identify campaign or we define campaign, at least from the media communication perspective. And if you look at Atkin and Rice definition, which is a definition that is worldwide used to define what communication campaign means, is a purposive attempt to inform or influence behaviors in large audiences within a specified time period, using an organized set of communication activities and featuring an array of mediated messages in multiple channels, generally to produce non-commercial benefits to individuals and society. So I've highlighted, key words, few keywords here that is very important in our definition of what communication campaign means. So a campaign is to influence behaviors. So it is naturally designed with the intention to change or to influence people's behavior. Well, in health is particularly more towards the positive health behaviors. And it targeted a large audience. And there will be, or there usually are specific time periods associated to campaigns, because a lot of the campaigns are program based, and they would have like a timeline in terms of when the campaign runs and when it ends. So there should be some kind of results that can be measured towards the end of the campaign itself. It also highlighted that communication activities is being used as, you know, the major part of a campaign itself. It could include mediated messages, but also in health, it also includes non-mediated messages or non-mediated communications, and across different platforms, whether it's interpersonal or through mass media, social media, community media. And at the end of, you know, campaign is to benefit the behavior change that is intended or hope to be achieved, is intended to benefit individuals and society at large. So in health communication, in health communication campaigns is very important, is widely used, and it's a strategy that is very familiar or very widely used by public health personnel. However, because of the term campaign, or the term campaign is being looked at not just you know, communication, the definition can be very limited. So a lot of health campaigns, for example, focus on educating. So it's more on health education. And you know, not all health education materials are particularly or are actually utilizing communication strategies. So basically, you are giving facts, you are using text or visuals to deliver facts to educate people, but you are not necessarily using any marketing tools or any communication tactics to make the messaging more interesting, more persuasive, for people to feel you know, they're more interested to take that behavior change. So it is very interesting to highlight this, because this is what is the gap is, or things that can be improved in the health sector. And that is why I feel that the work in health communication has focused on this, because we want to push for you know, the recognition of communication and media, social sciences, basically, to help people who are trained more in public health, in, you know, the medical or the health sector, to understand how to use communication. And there is an art to communicate, to get people to understand, to persuade people, to make people feel interested, and in this context, to take the vaccine. Okay, so I wanted to also touch on something that can be seen as part of a campaign, but it's not really a campaign. So previously I mentioned that in different sectors, when we talk about campaigns, there's just different definition of it, and then people might just assume that like a vaccination rollout program is a campaign, it's a vaccination campaign, but it's not necessarily a campaign. It's the whole program. The campaign, it can be part of it, but definitely all the structure and you know, support resources are very important to make sure a campaign you know, to increase the success of a campaign itself. So we have, for example, in vaccination, we have infrastructure and logistics. if we, a country has or provides a lot of, spaces, physical spaces, buildings, centers, vaccination centers that is available, is accessible to different groups of, in the community, not just people with access to transport or access to the location, but also making the access to the communities, the marginalized communities who don't have the logistic access going to the big vaccination centers. So these are all the infrastructure and logistic support that can play a role to as part of the vaccination rollout program. And we also have like infrastructure in terms of recording vaccination different vaccination doses or follow-ups or appointments. So in different countries, there are different systems. Like in Malaysia, we have everything online on an app called My Sejahtera, where we book an appointment online. But also that, but that is that is one of the way, but it's not the only way. I mean, there are other ways of making appointments. And how would people without access with smartphones or internet access be able to book an appointment or get themselves vaccinated? So these are some of the examples of infrastructure and logistics that could help with vaccination rollout, but not particularly related to campaigns itself. There's also support in terms of the funding and resources. We know that different countries have different access to vaccines, different vaccines, and I know countries in especially the low and middle income countries are struggling, especially in the beginning of the vaccination rollout, to secure vaccines to their countries because of funding limitations and relying on donations and aids to get vaccines to the country, whereas some of the probably the higher income countries in the Southeast Asia, such as Singapore or even Malaysia, have probably more faster access to vaccine itself. And there are also different kinds of resources. Some are self-financing, some are sponsored, and different there are just different modalities in healthcare system around the world that is influencing how a campaign, vaccination campaign rollout looks like. There's also the issue of power and network in the global community itself. Certain countries have certain power toward vaccine diplomacy, negotiating access to different vaccines, buying, different types of vaccine, sort of perceived as high quality vaccines, and it's just a whole lot of dynamics in terms of the power and network in the global in the global between countries and the relationship we have, political allies and whatnot. And also there's capacity in the country and policies that may support or may delay certain kind of vaccine rollout program in the country. There are countries that are able to develop vaccine on site in the country itself, that can produce the vaccine itself. There are some countries who are not able to, and how much of the healthcare capacity is able to support this vaccination program. So these are all structure and support that is part of a vaccination rollout program, but not particularly related to vaccination campaigns. So there is a different, I would say, separation when we talk about campaign and the program itself. Okay. All right. So next, so now that we have a clearer definition or sort of how I want to look at campaign when I want to sort of analyze or give some of my observation on the campaigns that we have on vaccination, on COVID-19 vaccination, I want to come in and talk about how to analyze or how the processes of a campaign looks like. So basically there's three parts. The first part is the sort of the pre part, which is involving the planning. The second part in the middle is, during the activities, during the vaccination campaign. And also the far right is actually the post campaign. So the first part, which is the planning, consists of formative research. So analyzing the situation, what is the current problem, what are the concerns that people have, what are the barriers, the challenges that people have to accepting a vaccination. So Tina has earlier in her sharing, she talked about vaccine acceptance as in a spectrum, because a lot of us actually falls in the middle, and we have concerns, we have questions on COVID-19 vaccine because of the nature of the pandemic itself, right? Because it happens so fast, we're unsure of what this disease is, what this virus can do to us, and how fast the vaccine is being developed. And we question, how safe is the vaccine. And I just wanted to point out that even I myself, have questions that I ask, and I mean, I think that is just part of us being human, because we are, in the mode of trying to protect ourselves, and they are. I think this is only natural when there are certain or new I guess new health issue, especially as big as the pandemic, has an impact on us and on the society. So it is only natural to feel that way. And during the situation analysis, it is very important because being a media communication scholars, we know that there is no one general messaging that could fit all, right? We know that the best kind of messaging are tailored messaging. We need to cater for the audience or the people that we want to target this messaging for. So for different kinds of concerns, for different kinds of barriers, there will be different kinds of messaging in the campaigns. So although we can have a general campaign that could address like knowledge or just getting people to know what it is, but when we talk about specific concerns, like when Tina was saying about, different kinds of maybe misinformation that is going on about COVID-19 and COVID-19 vaccine, we need to understand why people are feeling the way that they feel, and what actually contributing to them feeling hesitant towards taking the vaccine. So it is very important to have a situation analysis before developing any campaign. And part of the planning itself is setting an objective. I think maybe most of you are very familiar with setting the SMART objectives. So making sure that the objective of your campaign is specific, is measurable, is achievable, is realistic. There is a time bound to the program, the campaigns that you are set so that you can measure to at the end. So an example would be like, 80% of the targeted community can identify how vaccine works to protect individual and community by June 2021. Okay, so it has to have, like, every campaign needs to have a SMART objective, because then you are able to measure in the end how success your campaign were. So you need to be looking at the planning part very carefully before actually developing the messaging, developing and deciding what kind of platforms you want to do, or what are the communication activities that you will be part of this campaign itself. So when we talk about communication activities during the campaign itself, we want to plan with both using mediated communication and also non-mediated communication, because both communication approaches are very important. Not one can be better than another. I think both of them are very crucial in communicating a message more effectively. Mediated communication is, for example, with posters, infographics that we see, and through different platforms, can be mass media, can be community media, social media. So we push communication messagings in these platforms as a way to reach a larger audience. So those are the mediated communication strategies that we can look at. And we can also strategize to use non-mediated communication in our strategy as well. Using interpersonal and group communication, using non-verbal communication, using opinion leaders in communities, social listening, using persuasion techniques, healthcare providers themselves, when they see the patient or they talk to the community, all these are very important, because a lot of people, when they say about media communication, they would assume, oh, using media, but actually the interpersonal communication, the group communication can have a bigger role in persuading people, because in our social circle itself, we can get all this information about vaccination, but maybe the person who actually influenced us to go take that, vaccine is our partners, our husband, our wives, maybe our parents. Maybe the reason why, our parents would take the vaccine is because, the children are persuading them to take it. So we can't just disregard, non-mediated communication in this whole campaign process. And so the end is obviously the behavior, intention, and people getting intent to get vaccination, and people completing the COVID-19 vaccination. I am very bad with timekeeping. I'm just gonna, Dr. Sa, how many minutes do I have right now?
No worries. Maybe we can go about another 5 minutes, Dr. Ima. Is that okay?
Okay, can. I'm just gonna go very quickly then. So there's a lot of, like I mentioned, there's a lot of concerns that is out there when we talk about, vaccine and taking COVID-19 vaccine. There's like the side effects, there's whether, there's people maybe have needle fears, there's people who have like religious concerns, whether the vaccine is halal or not. There's people who are evaluating their perceived benefits and barriers. There's just so many other things that needs to be analyzed when we do the formative analysis. And when we want to develop measurable campaigns, we want to see changes in 3 parts: knowledge change, attitude change, and behavior change. So when we talk about knowledge change, it's probably, I'm giving you some examples here, like using facts and like graphics and to actually explain what vaccine is, what does vaccine efficacy means. So this is actually trying to explain us in a simple and relatable language to get people to increase their knowledge on what vaccine is, why it is important, how does vaccine works. So you can see actually the increase in knowledge would be able to influence the cognitive brain to understand why we need to take a vaccine. So these are local examples that I've taken from the Ministry of Health. You want to even address the knowledge gap from how to register for a vaccination. How do you want to actually go and get yourself registered to be in line to get this vaccine? How do I get appointment? So even the knowledge in terms of how to needs to be communicated in a campaign. And on the right side is how the vaccine is being secured and the whole vaccine procurement process to Malaysia. This is also very interesting, using very simple way to explain in layman terms, how does a virus looks like and how does, a vaccine is looks like, basically. So I really like how the graphic is being used here, how different the antibody is used, is matching with the shapes of the kind of pathogens or the virus that it has, so people can actually see this and relate this and kind of understand why. So if our body has the sort of the arms to actually capture the virus, right? So it can be easily tackled. But if we don't have it, so the virus, the virus just lives in our body and are not being dealt with. So using this kind of explanation is very key to increase knowledge about what vaccine is. There's also like change in attitudes, like I mentioned earlier. So knowledge is one part, attitude is another. So attitudes is much harder to influence because it will affect the emotions. It will affect the affective part of your brain, of your heart. So this is where I would say the non-mediated communication plays a role in a campaign, using opinion leaders, using people with experts to talk in the media, to justify, to rectify certain kinds of, or to correct different kinds of misinformation that is available. These are some examples of how we want to tackle the tips to get people to tackle attitudes toward the elderly to get vaccines. So the post is actually giving tips on how to persuade your parents to take the vaccine. So it's kind of like part of knowledge and also part of attitudes there, because it can try and influence attitudes of the older generation. And also we see a lot of campaigns that focus on factors that is already well known in a lot of theories that we use in health behavior theory of behavior TPB, so perceived severity, perceived risk, and also using fear appeal. There's a lot of I think theoretical applications seen in local campaigns. there is actually quite a difference, I would say, in the local campaigns in terms of the language use, and the campaigns that was used in, for example, in WHO. I think it's much more relatable when you read, and much easier to understand when you read the WHO campaigns. However, it's not available in different languages. So, you know, in the end, we have to resort to the local content that needs a lot of improvement. I've talked about non-mediated communication. We can work with community leaders, building social norm in community. And when we talk about campaign effectiveness, I would say it's, especially with the vaccine, COVID-19 vaccine campaign, it's very hard to measure, because we don't know whether there were any proper planning in these campaigns, and therefore you don't have any sort of indicators to evaluate more objectively on an effective of the campaign, because an outcome, for example, how many % of a population actually gets vaccinated, is not necessarily a result of the campaign alone. Okay, so enable for us to measure campaign effectiveness, we need to control confounding factors, and therefore planning, when we're planning a campaign, we need to already put into place, how are we going to measure this in the end? What are the indicators that we want to measure in the end? And you know, what we learn is that behavior change is very complex. There's a lot of issues that needs to be dealt with, and tailored messaging is so important. So we may, end up with 100 kinds of campaigns, basically, because we are so diverse and so many different issues need to be dealt with. And I just wanted to go very quickly before I end, is just to highlight a very interesting of observation in Malaysia, but this one is not particularly on the vaccine, but it's on COVID-19 itself, where we have a sort of a inbreed campaign that comes from the society themselves, which is the Kita Jaga Kita campaign. So the Kita Jaga Kita means we take care of us. And these values are anchored in community collective spirit that cut across different communities and resonated at the individual and community level. And it's so interesting because it is the individuals are invested in themselves, and they have increased self-efficacy to solve community's problem. And I think it's something that we need to tap into when we talk about building campaigns, because it is something that we are observing that emerged during the COVID-19, where people feel the responsibility to step up and take care of their own holistic well-being. And I think the challenge here to think how we can create a friendly ecosystem to facilitate this. So yeah, so my last slide, I'm just gonna go very quickly to talk about challenges and our way forward. This, we understand that COVID-19 was an unprecedented event, that there's just a lot of uncertainties, and yes, planning a campaign in the COVID-19 era is quite very hard, because there's just a lot of things that we don't know. But what we have learned from COVID-19 and COVID-19 vaccine campaign, that we can be better prepared. And we can't predict the next pandemic, but we can try and prepare for it. And what the things that I have to emphasize here is, when we develop a campaign, we need to make sure that we are able to monitor and evaluate using indicators that we have set early on that matches with our objectives. We need to be working with different parties, and as Tina says, maybe it's different than the original or the existing parties or collaboration that we have. And we need to build trust and resilience in communities, because the community themselves can actually be part of a campaign and build a sustainable campaign using probably social media or interpersonal communication itself. And lastly, I believe that we need to invest in social scientists, more people in health behavior change, communication, psychologists, culture anthropologists, media communication experts. We need to invest in social scientists because these are the people who could help in developing a better campaign in the future. All right, so that's all for me. Thank you very much, everybody, for listening. I hope that my sharing here has been beneficial to you. And yeah, so thank you very much. And I would like to pass back to you, Dr. Saab. Sorry for taking a long time to do my presentation.
Thank you so much, Dr. Emma. Yeah, so I've been furiously writing notes. I really have lots of ideas about research and, things that we could, as an academician, what I can research on, what I can discuss further, especially on health communication. It's very interesting, what Tina said about, how the trust in government could affect vaccination rates as well. And I really like what you said, Dr. Emma, about, a lot of health campaigns are educational and it does not have, did not use communication tactics to make it more engaging, more persuasive, more interesting, and persuasive for people to make behavioral change. So that's my take from that. So I was just wondering if there are anybody in this Zoom who would like to pose any questions to our speaker here, Dr. Emma. Please feel free to raise your hand virtually and ask the question. Anyone?
I feel very nervous because I'm the only one who needs to answer.
Hi, can I pose a questions?
Yes, go ahead, Radwan.
All right. Good afternoon, everyone. Hi, Dr. Emma. Was a very good presentation. Okay. I think everybody is aware that many individuals may have limited health literacy skill. Yeah, meaning they may have struggled to understand health information or make informed decisions about their health. Yeah, don't be surprised. This can lead to poor health outcome, such as a lack of adherence to medication regimen or lack of compliance with the preventive health measures. Yeah, I don't have the statistic for Malaysian health literacy, but my question is from a health communication perspective. Yeah. Would you agree that the IoT, e-campaign, you've been talking about campaign, I'm talking about e-campaign right now, everything is digitized, be one of the best platform for increasing people's health literacy? Yeah, if yes, how about those who are not connected to IoT? Will they be left out? Thank you very much.
Thank you very much, Dr. Radwan. I have happened to work a lot in health literacy, and I've been helping Ministry of Health to develop instrument to measure health literacy in Malaysia. And I could actually say what's the health literacy level in Malaysia right now. Past National Health Mobility Survey in 2019, we have seen that health literacy is measured in four capabilities: access, understand, be able to judge or appraise health information, and be able to apply this health information into behaviors. So Malaysians have very high access, and they relatively also have high understanding of basic information, functional health literacy. They know how to read the labels in medicine, for example. They know how to read and understand certain health information. But what is a bit low in Malaysia is in terms of the critical ability to evaluate health information. So judging health information is quite low in Malaysia, and this is actually one of the things that will be the emphasis in the development of the national health literacy policy in Malaysia. And this is actually part of the 12th Malaysia plan. And my team is actually part of engaging with the stakeholders to look into, what can be improved in terms of health literacy in Malaysia. I love what you mentioned about, the internet is fantastic, right? To get people to get more access on information, and there's a lot of tools to actually get people to evaluate, have information, fact check, for example. But there's also like a lot in our community that don't have access. They don't have, resources that can help them to understand information, to evaluate information. Last weekend I was actually conducting a focus group on health literacy at one of the PPR. So what's PPR in English? Is low low income area, low income area, and this is low income area in KL. So it's in Kota Damansara, but so we would assume that people who are living in this area, even though they are living in a low income flats, that they would have access, they would have smartphones, for example. But it's so interesting when they were like basic issues were raised, like for example, I can't use why I have to pay 1 ringgit for to get access to health and medication, but they asked me to pay using QR code, and I'm like, why do I have to pay using QR code? I don't know how to. And we are talking about people who live in the city, people who live in Kuala Lumpur. And I mean, what more for people who are living in the suburban area, living in the villages, living in the, what is QR code? They probably don't even know what is cashless, wallet looks like. And to them, why do I need to pay using my phone when I can just take out 1 ringgit from my wallet and just pay? And it doesn't make sense to them, right? So this, while we are trying to develop and strengthen our internet infrastructure system, integrated system, we are talking about all this like big words, but it means nothing if we don't actually equip our people to know how to use it, to make them feel it's actually easier to use it, so these are the things that needs to come together with developing integrated system, so you need to make sure the community themselves are ready for this, so that it doesn't become like a white elephant. It doesn't just become something there just because it's so awesome, but people are not using, or at least there are pockets in communities that are not using it. So yeah, so I think it's very important to consider all this issue when we want to get our society to be more health literate.
Thank you very much, Dr. Imam. Last one. And do you think SKMM, our Suruhanjaya Komunikasi and Multimedia, will play a very important role beside KKM?
Yeah, I think, MCMC generally, not just, helping with regulating misinformation related to health, but also in other aspects as well, right? So, in the health sector, yes, we do have KKM, we do have the Ministry of Health, we do have MCMC collaborating and helping, and there are a lot of other fact checkers, independent fact checkers out there who are helping with to combat all this misinformation, all this infodemic that's happening. I do wanted to probably say in the context of Malaysia, we always like, I don't know whether it's the history of it or how we are wired, but we always see that regulating things is the way to go. Like film, we need to censor things, we need to regulate, we can't let certain scenes be shown because we need to protect our children from this scenes or this immoral content. But wake
Too much
up.
of taboo.
I know, like wake up. If they don't see it in the mainstream media, they will see it in the internet anyway.
Exactly.
So what's the point of regulating when what we should do is to make our society more resilient, make our society more of a critical thinker, right? Question, to be able to be smart enough to decide what is good and what's not, So I think regulation is one thing, but I think preparing or, getting the community to be more resilient is better. But I also feel that this is, we're just still paving the way. There's a lot of challenges, but I think the more we do it, the more people talk about it, the more awareness we have. I mean, like, we always talk about, oh, we need to prepare our younger generation to be media literate. But actually, I think they are a lot more media literate than elderly generation. I tell you, like my kids, they're like, this is right, mom. Like, I don't think this content, I think we need to go and search from this sources and that sources. So I think they have more savviness in that area because they grew up with that, so it's just trying to educate them to be more critical thinkers. But the elderly generation, our generation, we are probably more at danger when dealing with information because we're so gullible, we're so easy to be fooled, I guess.
Yeah. All right. Okay. Thank you very much, Prof. Yeah. All right. Okay.
So Dr. Emma, we only have time for one more question because it's already 4:30. So Kamran Naha, can you please go ahead with your question?
Thank you so much. And good afternoon, Dr. Emma, and thank you for the wonderful presentation. I actually have two questions for you. The first question for me is that if we only look at the context of Malaysia, since the beginning of COVID-19 only, since the beginning, the vaccine uptake has been quite high, and the notion of getting the herd immunity and all in this area, Malaysia has been reported as like one of the successful countries and all. So, and I am talking about the stage when it was the peak moment of the COVID. Now we are moving towards the endemic, so the risk perception is quite low. So since we have already achieved that success I'm talking only about COVID. So since we have already achieved that success, so what is the, at this stage, what is the importance, or to what extent it is important to study people who are still hesitant or completely against COVID vaccine or any other vaccine? So this is my first question. Do you want me to ask the second question as well now?
Oh, okay. Sure. Yeah.
And my second question is that when it comes to, actually I myself, I'm doing a study on this. And from my, from my data collection experience, I'm asking this question is that when people are hesitant, they have this notion. Attitude changing and trust building is already a difficult process, right? So at this stage, at this juncture, when they face that government is not saying that the COVID vaccine is mandatory, but then those who are saying anything against that, the forceful down of social media pages and all, I mean, forcefully closing those. I know it's a successful strategy. It has been proved to be a successful strategy to stop the spread of misinformation and all. But then it has, in other way around, don't you think it has sparked the further confusion and doubt, like why is government stopping and arresting, or maybe doing this kind of aggressive steps to counter any information that says against the COVID-19 vaccine?
All right, thank you very much. I think it's very hard to answer your question, but I shall try. Yes, I do agree that as we go into the endemic stage, people are having less perceived risk of getting COVID-19. More and more people have been infected, so they don't feel that, I've built my natural immunity, and that's supposed to be stronger than the vaccine itself. I don't know how many of us have actually taken the booster, the third booster or the fourth booster. I had to take it because I was traveling, so there was a reason why I took it. But I understand that, like, there's a lot of reasons why people don't want to take it anymore, right? Because it has become like an influenza shot. Like, it's something that is more built in, that we have to take it every year. And honestly speaking, how many of us are actually taking influenza shots every year? So I would assume that, COVID vaccine booster would have the same effect. Like, less and less people see the severity of COVID-19 towards their health, the less they feel that it's important to take the routine shots. But I think it's also about like in my talk, I talk about doing formative analysis, and if we are trying to campaign for people to get booster shots, to get regular vaccination every year for COVID-19 or for any kinds of influenza, we need to be understanding what are the issues underlying. Is it because the perceived risk has gone down? Is it because people just don't care anymore, or is it because people have built in and feel that, yeah, this is a conspiracy, so I'm not gonna subscribe to it anymore? So we just need to understand what are the issues first, before we want to, I guess, try and communicate to persuade people to take routine booster shots. So it goes back to the whole planning of the campaign. It needs to be done carefully, meticulously, and seeing what are the issues. I mean, we can do social listening, we can look at the sentiment analysis on social media and see what's the pattern like, and go down from there, to identifying what might be the concerns. The second question, can you just repeat the question?
Yes, actually, my first question ended with the fact that at this stage, is it any more important studying people who are completely against COVID-19 vaccine, since the risk perception or the severity of the disease has been normalized to a great extent? And my second question is that just now you mentioned that we should go online and do the sentiment study and other stuff as well. So here comes my second question, is that when people are saying, posting negative comments, some of them are maybe rationally, reasonably negative. Some of them are maybe the misinformation or the conspiracy theory related information. But when government takes initiative like tracking down those people who are saying negative about the vaccine or spreading misinformation, track them down or completely put down the social media page. Do you think it is an effective strategy altogether to, pursue people or change their attitude?
Yeah. I think it goes back to when I say, it's just how we are wired to say everything needs to be regulated, bring down, all the negative postings and, control, trying to control. But it's not, to me personally, I don't think it's the best way to move forward with this, because there's just so much, that you can do. And it goes back to building the trust, right? If you really transparent, if you are really doing the right thing, why are you so afraid, and trying to tackle it by, I guess this is a coward way of, if you can say, of dealing with it, because you just don't want to deal with it, you just delete it and you don't have to face it. Yeah, so I know it's hard, but I think, like, what's important is to get people who are advising them to actually see. It's actually very hard, even in crisis communications. It's the best way forward is to be truthful, to be honest, to take responsibility of your action, even though you did something wrong. And that would actually build a better image and repair the image that you had, damaged through the crisis, rather than trying to silence certain voices or trying to, not answer anything or trying to be arrogant about it. It has, research has shown, through different case studies, that this doesn't work in a crisis communication. So personally, I don't think that's the best way to do it, to go about it. Yeah.
Thank you so much for the wonderful answer. Thank you.
Thank you so much.
Thank you so much for the questions. And also thank you so much, Dr. Emma. We have run out of time. We have, overrun by 10 minutes actually. Thank you so much for everybody here. I have shared a link in our chat box. If you do wish to receive a copy of the deck and also a recording of today's webinar, please do fill in the attendance form and we will email you with the relevant links. Thank you so much, everyone, for being here despite it being overrun for 10 minutes. I had a really, I think it's really knowledgeable and it's very insightful what Dr. Emma and Tina has shared with us today. We are planning future webinars as well. Alexander, would you like to say something before we end our webinar today?
No, Dr. Sabaria, you can end the webinar in just 2 minutes. Maybe let me just say briefly a couple of things. All right, so thank you very much. I'm very happy, really very happy with this first webinar, and you really pulled it off. So first of all, thanks to our speakers, Tina Purnat and Dr. Emma Mohamad, for your truly insightful presentations on the effectiveness of COVID-19 vaccine campaigns. You are outstanding speakers. I'm so happy we could invite you, and that's thanks to Dr. Sabaria. She invited you, and yeah, she's the chief organizer. And thanks for planning this webinar. Then also, we should not forget some other people. I'd like to thank our executive council members, Alonso, Dr. Tu, Ina, Jason. They've all been a great help in making this webinar happen. And then, well, thanks to our members for showing up today. We had around 40 or more participants. That's wonderful. And thank you for your questions and for participating actively in this webinar. As Dr. Sabaria said at the beginning, Our council is planning more activities, more webinars. That's one thing. So we'll see how many we can have, you know, maybe every 2, 3, 4 months. We'll find out. The future, we'll see. And but there, you know, there are many other opportunities for the SEAMSA members to become involved. We're planning to have a conference. We have the journal. We have the special interest groups. And also, we are looking for a publicity director to join our council. So to stay up to date with what's going on, I recommend that you check Facebook regularly or follow us on Facebook. Where else? LinkedIn. And we have our announcements also on the website. I think we have a Twitter account too that needs to be updated, but then we also have a YouTube channel. So we'll see whether we can put this recording here today on YouTube or not. We'll find out. But there are many ways to stay up to date with what's going on at SEAMSA. So, well, that's all for me. Thank you so much, everyone. Back to Dr. Sabaria.
Thank you so much, Alexander. Also, if you are not a member of SEAMSA, do become a member. We are currently having this promotion where, you know, you don't have, I believe you don't have to pay membership fees, right, Alexander?
Well, this year and next year, no membership fees to help our organization grow a lot. And we already have hundreds of members now, so we are growing fast. Oh, I forgot to say, our 2 speakers will receive a certificate of appreciation very soon. It's already signed and done. You'll get it soon.
All right. So with that, in the future, actually, we are planning to have a webinar on elections and disinformation. You know, with the upcoming elections in Malaysia and, you know, elections in the Philippines and Indonesia and all that. So that's part of our plan as well. And another one, it would be dismantling racism and celebrating cure. So that's going to be an interesting one as well. So that's part of the plan in the pipeline. We'll keep you guys updated. And thank you so much, everyone. Thank you again for attending to this webinar. And we hope to see you next time. Thank you.
Thank you.
Thank you all. Bye-bye.
Bye.
Have a good one.